our side on our own. We don't know what the new technologies are. So we really need to combine the expertise, and we need busy surgeons to find time, to dedicate time to this research, translational research. So I think it's definitely the way to go. In France, we've been not good at taking time out of the surgical practice, but now we suddenly realize that if we really want to fly, we need to have at least a full day dedicated to that collaboration with the engineers.
Okay, so you and I have been talking, but there's also an opportunity for the audience to actually send in questions. And there's a couple of questions. You have to text DeBakey to 37607, and you can send in questions. And there's a couple for you. You mentioned the importance this morning of endo and open expertise. Okay, that sounds great. Now, how are we going to ensure our trainees get exposure to both of these?
The only way to have the trainees to get exposed and train in both open and endo is to have training programs in high volume centers. It's funny, when I moved to my new center, they were almost only doing open. You would think that by me coming there, the
Why
open
would they want you?
the open would go down and the endo up.
Yeah.
Well, actually the endo went up significantly, but so did the open.
Yeah.
Because again, I'm not promoting endo over open. I'm just trying to figure out what's the best option for each patient. So we discuss all those cases, and because many patients are referred to me will finally end up with open surgery, we are high volume centers in both open and endovascular. So our trainees do rotation. They spend every month, they come, they are either in the hybrid room or in the open rooms. And so we have 3 fellows, and they rotate, 2 in the open, 1 in the endo. And so by the end of their 2-year fellowship, they have been exposed to both open and endo.
All right. Yeah, I mean, we're fascinated a little bit by what's happening here is that we now train vascular surgeons out of medical school. 5 years, you're a trained vascular surgeon. But because we're so integrated with cardiac surgery here, our trainees rotate with the cardiac surgeons. They're our partners. And 2 or 3 of our vascular trainees are now going to do cardiac surgery. And I really think this is a way that cardiac surgery can be transformed because our guys know how to sew guys and gals, actually, increasingly gals, know how to sew anastomoses. They know about imaging, they know about catheters and wire skills, and that can be transplanted. And so we talked a little bit about, when I came down to Houston, the word that was pervasive was cardiovascular. And I went, that doesn't exist as a specialty. But the more experience that I've got, I suddenly realized there was a lot of wisdom in that, and that we're kind of going back to the future. And I know you've kind of got some opinions upon how you work together with your cardiac surgeons.
So this is a very highly sensitive
very sensitive
question.
We have to parse our words as vascular surgeons very carefully.
There's a lot of politics involved, but when I look at the field of cardiovascular surgery, I think there's part of it is really cardiac surgery, transplant, a valve repair, thing like this. Part of it is really vascular, which is peripheral, AV access, thing like this. And then you have the aorta in the middle. And I think if you want to be a good aortic surgeon, so you need to be both exposed to cardiac surgery and the vascular and vascular surgery. So we need to be able to have a training program combining exposure to both cardiac surgery and vascular surgery, and we need to have a treatment path that includes both expertise. When I do my endovascular arch repair, I scrub in with a CT surgeon because this is the safest way to do those procedures. And anything goes wrong, I cannot fix it. So, I mean, we need to be able to work together. Obviously, every center is different, every country is different. There are financial issues, there are political issues, but at the end, patient care is what we are doing. And I think that having a combined approach is the best.
Yeah. So one of the arguments I've had, obviously I'm a vascular surgeon, is do societies exist to protect a specialty, or do societies exist to improve the vascular care or the cardiac care of the general public? Clearly it's both. But at the end of the day, I think being able to improve the cardiovascular health is our primary mission, and we got to figure out the politics, that get in the way basically of doing it. I said it, you didn't say it, I'll take the blame.
No, but
okay.
As the ESVS president, I've been a lot involved in those discussions, and what I can tell you is, for example, for the guidelines, so we published a combined guidelines between the EACTS and ESVS for the arch, and we're are going to update our thoracic guidelines soon, and some of the chapters will also be written down by a collaboration between cardiac surgeons and vascular surgeons. So we're we need to have this sensitive approach.
Okay, so one other question, probably from one of our residents, I would imagine, given the flavor of it. Do you have an approach to resident didactics and education, both in and out of the operating room, that has worked well for you and your trainees? What's your philosophy, and how do you kind of engage education? Well, we all have certain didactics we got to teach, and you teach in the operating room. Is there a way of, how do you basically do it?
So first we have conferences where we discuss all the cases like this morning, and it's very important to show them that there are many ways to tackle one problem, and we need to get them involved in those conferences to present the cases and everything. Then there's a treatment path, and we try to make this very crystal clear on a patient that comes to the hybrid room, that making sure that they've been prepared the right way. What we've done on top of that is what I've seen today at the Methodist is we've had a specific training program that is not on patient. We have a hybrid room dedicated to research and training. We have 3D prints that are connected to a positive flow, so the residents and the fellow, they can do a iliac branch, a fenestrated repair in a real life environment exposed to radiation, so they learn how to use this advanced imaging application. They learn how to use those complex endograft, and so the next day when they're in the OR to help us perform those cases, they fully understand what's going on, and then we can slowly get them to do those cases in a very safe and progressive way.
Very good. Let me pick your brain on one last thing, and that is, as a European who came to the United States, I came here because all the new technology was taking place in the United States, only to find that it actually was now moving to Europe, and Europe was on the vanguard of getting all the new cutting edge technologies. But that regulatory environment in Europe is changing. So can you talk a little bit to that? So
I'll tell you a joke. A couple of years ago, we would say that any new technology will first be implanted in humans in Australia, then in Europe, then you would have animal models, and then it will come to the US and finally to Japan. This obviously is changing. The new European rules are much more, how would you say, exigent, we say in French, exigeant. So we now need to go through a whole process that makes full sense, but that means that we will have access to all those new devices after you in the US. So we've been spoiled during many years, having access to all those new devices. Probably things are going to change now in the near future. You will have access to the device first. What is interesting is we still need to have centers that will evaluate those new technology and will share it with the rest of the world. And I think what's going to change also is, rather than having European and FDA trials that are performed separately, we will have global trials and notified bodies will work on global data. And I think this is really the way forward. Currently, for fenestrine branched endografting, the best data available is the US IDE consortium. The 10 IDE centers are combining all their prospective database. This is what we need to do, is gather data from everywhere, have the same database, and share experience.
All right, so you got one more question. Based on your experience, how do you see medical device and imaging companies coming together to solve complex clinical challenges?
So that is a very interesting question. I think why robotic companies have failed in the past is that you had the robotics on one side and the imaging on the other side. Now, if you combine robotics with a 3D imaging data set, and then suddenly you can ask the robot to go towards a target vessel without touching the aortic wall, so avoiding all the trash emboli and making all those complex procedures much more simple and with better outcomes. So it's an evolving field, and obviously very soon, and you're working on this here, you will be able to do a procedure from your smartphone in a patient that is a couple of 1,000 miles away. This was not yet there, but we're moving forward, and the key is really to connect all those robotic devices to the 3D imaging. And until we have those companies working together, when they will be working together, we will be able to tackle much more challenging pathologies.
So it's a very interesting stage in that evolution. I mean, you got to give credit to Philips, kicked this off with the acquisition of people like Spectranetics, and now you've seen Siemens buy Corindus, and you know, I've always felt that the link between the imaging companies and device companies, people like you and me going, you guys really need to be talking to one another, but you're actually seeing it starting to happen at the moment. So within the extent that you can talk about it, what can you tell us about shape sensing technologies?
Which technology?
Luna, the force, you call it?
Yeah, the force.
Yeah.
So it's one. This is one optical lumen. This is one of the technologies out there that is going to change the hybrid room setup. So what is the hybrid room? How will the hybrid room look in 10 years from now? Will we be using radiation? Probably yes, but how much of it will be under X-ray guidance? I'm not sure, because force technology is there, because electromagnetic fields are here, because MRI is on its way, because ultrasound and 3D ultrasound, all those non-radiation technologies are there to help us perform those procedures and reducing our exposure to radiation. Because when I see a young vascular surgeon today, I know that he's going to be exposed in 80 or 90% of his practice to radiation. So first we need to make sure that we protect ourselves correctly currently, and then we need to move forward with all those new technology, evaluate, and some of them will be used in routine practice later on. And the one nice thing about those technology, if I think about the force, for example, is it can actually bring you to very extreme angulation that you cannot have with your gantry, with your C-arm. So it's going to help you have information such as information you would get with the biplan, but without doing any radiation. So I think it's the way forward, but I cannot tell you tomorrow which of these technologies will be prominent in the hybrid room.
Stefan, I could pick your brain all day because you're such a font of knowledge about some things that I'm very interested in, but thank you very much indeed for coming over here. It's really been a transformational visit from our standpoint of view. And
thank you for your invitation, and I've been really impressed with all the research going on here and with all the education facilities that you have. It's truly the way to go, and I've learned a lot. Only 24 hours, but it was really worth the visit. Thank you so much for
the first of many. Thank you very much indeed. It's a real pleasure. Yeah.
Thank you, Alan.